Hello, everyone. Welcome to the Grand Rounds on Duchenne muscular dystrophy and gene therapy. What's on the horizon? I am Dr. Veera Pandian. I'm a pediatric neurologist and a neuromuscular specialist at Arkansas Children's Hospital. I'll be talking to you guys about the Duchenne muscular dystrophy and the upcoming gene therapy programs today. So these are the learning objectives. We're going to look at the components of gene therapy for Duchenne muscular dystrophy, such as the transgene vectors. We're also going to look at the different clinical trials that have dosed the gene therapies for Duchenne muscular dystrophy and look at their outcome data. So before we jump onto the gene therapy trials and information, let's talk about what is Duchenne muscular dystrophy. As most of us know, it is X-linked muscular dystrophy. It usually affects the boys, and it is due to a mutation in the gene DMD or dystrophin, which is located in chromosome X, P21, and it is X-linked recessive. And it affects about 1 in 3,500 live male births, and it is the most severe form of muscular dystrophy. But how do these boys typically present? They usually present with muscle weakness that's noticeable around 3 to 5 years of age. And as we all know, it is a progressive disease. As time goes on, the weakness gets worse, and most of these patients would be wheelchair bound when they're around 11 or 12 years old. And as time goes on, during the adolescence age, they can go on and develop cardiac and respiratory weakness as well. However, with the steroids and other therapies that's available, we're able to prolong their life, and we're also able to delay the loss of ambulation and delay the onset of cardiomyopathy and respiratory muscle weakness. Dystrophin is also expressed in brain, so some of these kids can also have behavioral problems. And a lot of times I emphasize for pediatricians, if you see any boys and you suspect autism spectrum disorder, just check their CK level. And those could be as high as 10,000s to 15,000s, and nothing else in boys cause that high CK. So sometimes these kids can present with autism spectrum-like behaviors around age 2, even before the muscle weakness manifests. So then when we talk about Duchenne muscular dystrophy, we also talk about Becker muscular dystrophy, which is actually a spectrum, and it is a milder version of Duchenne muscular dystrophy. They have later age of onset, and the progression of the disease is much slower compared to the Duchenne muscular dystrophy. Going back to the phenotype of Duchenne and Becker muscular dystrophy, it is a spectrum. Now we prefer to call them as dystrophinopathy, meaning a spectrum of disease that is due to an abnormal dystrophin protein. So this could include your Duchenne and Becker muscular dystrophy. There's also an intermediate phenotype which kind of behaves in between Duchenne and Becker. And they can have just dilated cardiomyopathy. Sometimes they can also have pseudometabolic presentations like exercise-induced muscle cramps and muscle pain, only with no muscle weakness. And they can also have just asymptomatic increase in the creatine kinase as well. And of course, females are carriers. Typically, when we say carriers, they do not manifest any symptoms. However, in this case, the carriers of DMD and BMD, they can have symptoms such as cardiomyopathy, muscle pain, muscle weakness, etc. So this is the DMD gene. Like we said, we call it DMD gene. It's one of the largest genes in the human genome. It has 79 exons, and it is located in chromosome X, P21, and it encodes dystrophin protein. And the dystrophin protein is expressed in your skeletal muscle, cardiac muscle, smooth muscle, and also in the brain. So this is a pictorial representation of the DMD gene and also the dystrophin protein in the bottom. As you could see, there are 79 exons, and these exons, they have different shapes, and with these different shapes, they would fit a puzzle together. And it is important, as I'm going to introduce this concept of reading frame. We probably heard about out of frame and in frame. Out of frame mutations typically cause Duchenne muscular dystrophy, a more severe phenotype, whereas the in-frame mutation cause a milder phenotype. So what does that mean? Again, as you could see, these exons have different shapes and they all fit the puzzle together. If someone, for example, has deletion of exon 50, meaning the exon 50 is missing, the exon 49 and 51, because of the shape, they don't fit the puzzle together. So this is called out of frame mutation and leads to more severe phenotype. Whereas if someone has, for example, exon 48 deletion, even though the 48 is missing, the 47 and 49 can fit the puzzle together. So this is in-frame mutation, and this typically leads to a milder phenotype. This is again the same reading frame concept, much simpler version. So for example, we read the sentence, the big red dog ran and sat. Think of these as exons or your codons within the exons. So if there is deletion of this G, the sentence doesn't make any sense. So this is your out of frame mutation, and that usually causes a Duchenne phenotype. And these boys do not have any dystrophin. Whereas if the same sentence, if this whole chunk of big red is deleted, the sentence can still make sense if you read them. The dog ran and sat. So there's two words missing, but the sentence can still make sense. This is your in-frame mutation, and this causes more of your milder phenotype, which is Becker or within the spectrum of this milder phenotype. This is the dystrophin protein within the muscle membrane. As you could see, there are multiple other proteins with dystrophin, including laminin, dystroglycans, sarcoglycans. All of these proteins are important to maintain the structural integrity of the muscle and also for the muscle contractility. And mutations involving any of these proteins can cause different types of muscular dystrophies. And of course, we are focusing on the dystrophin, which causes the Duchenne muscular dystrophy. So what actually happens in the Duchenne muscular dystrophy? So there is these mutations, right, out of frame mutations that cause absent dystrophin, and that actually triggers an inflammatory cascade or immune response that leads to muscle fiber injury and degeneration. And that kind of leads into both degeneration and regeneration, where the actual muscle is replaced by fat in the connective tissue. And that's why we see calf hypertrophy and other muscle pseudohypertrophy in these kids. So there are therapeutic targets being looked at targeting each step in this inflammatory cascade. So the gene therapy is actually addressing the absent dystrophin, and that's what we're going to focus on in today's presentation. So jumping into the gene therapy for Duchenne muscular dystrophy, we call it in vivo gene therapy. What does that mean is we're actually injecting the gene therapy material into the patient's cells. So there's ex vivo, meaning you actually take out the patient's cells, inject it outside of their body, and then you inject it back. That's ex vivo. In DMD, we are using this in vivo. And of course, we need a vector, a vehicle to carry the gene product into our cells. So the most commonly used vector for that is adeno-associated virus vector, which is AAV. They're kind of similar to adenoviruses, but they're not. They just like to hang out with adenoviruses. So they're called adeno-associated viruses. So why are we using these AAV as vectors in this gene therapy? So these AAV vectors generally have low immunogenicity, and they do not cause any infections in humans, and they have favorable safety profile. And they're also non-integrating, meaning they do not integrate into the human chromosomes. They just kind of hang out in the periphery in the nucleus. They don't integrate into the chromosomes. So these are some of the beneficial factors about AAV9. However, one thing to keep in mind is the actual capacity of this vector. So what happens when we put the transgene into this vector is these viral vector are genetically engineered to take out their material, and we put in what we call the DNA cassette. And this DNA cassette includes a promoter and a transgene. And the maximum size of this DNA cassette that a vector could carry is about 5 kilobases. And the transgene capacity, that the maximum that we could use would be about 4.7 kilobases. So this is important to keep in mind. We'll talk about that in a minute. So again, going back to this DNA cassette, so we have these different components within this DNA cassette, which is your promoter and the transgene. So promoter, it actually initiates the transcription, and it is also important to control the expression of your transgene. And the transgene is the dystrophin that we're going to use. And the promoters can have affinity towards what tissue that you want to target. For example, in the Duchenne muscular dystrophy, you are targeting the skeletal muscle. So you may want to choose a promoter that has affinity towards the skeletal muscle. Same for vectors. So different vectors have different affinity towards different type of tissues in our body. So for example, for AAV, there's different types of AAV serotypes from AAV1 through AAV9. And each one of them have different level of affinity towards different tissues, including your skeletal muscle, your cardiac muscle, your brain. So you want to choose a vector for Duchenne muscular dystrophy that has affinity towards your skeletal muscle and cardiac muscle. So getting into the actual strategy for the gene therapy for Duchenne muscular dystrophy. So we talked about the DMD gene, which is the largest gene with 79 exons. And then we also talked about the vector that we wanted to use can only carry about 5 kilobases. And the actual DMD gene or dystrophin protein size is around 15 kilobases. So how are we going to fit this 15 kilobases protein or transgene into that vector that can carry only 5 kilobases? So that's when we refer back to some of these patients that were reported in the literature. So the first one was reported in 1990. It was actually a 61-year-old patient who was actually ambulating at this age with Becker muscular dystrophy. And that patient had deletion of exons 17 to 48. About 46% of the coding region was missing. Then that gives us a clue. Maybe this exon 17 to 48 is not as important as we think. So using this as a guidance, different companies try to come up with different versions of dystrophin. We call them mini dystrophin or microdystrophin. Like I said before, the deletions, they're trying to come up with this construct by removing exon 17 to 48. So the actual size of the dystrophin gene is 14 kilobases. With this concept in mind, these miniature version of dystrophin protein has been constructed. And say the microdystrophin or mini dystrophin on their size now is around 3.8 kilobases. So now we can easily put them into the AAV vector. All right, now we're going to jump into the different gene therapy programs that have already dosed DMD patients. So we're going to talk about 4 different programs. The first one, SRP-9001, is from Sarepta. The next one is from Solid Biosciences. The third one is from Pfizer, and the fourth one is from Genethon. Then there's also other companies that are looking at different constructs, but they have not dosed any patients yet. Thus, you could see these different programs are using different type of vectors, but they're all within this AAV family. Then they also use different promoters, but all of these promoters have affinity towards skeletal muscle. And if you look at their transgene constructs, they're slightly different, overall keeping that strategy in mind of this mild Becker patient that was still ambulating at age 60. Before jumping into these different trials, let's look at what are the outcomes that are commonly being used in these DMD gene therapy trials. Of course, the first and foremost is the safety. Then we can also look at the dystrophin protein expression, how much of dystrophin is being expressed in this muscle tissue after giving the gene therapy. And then we can also look at the functional response. So we use different tests to look at the functional response. Most of this are being done as standard of care in our clinics. I want to take your attention to North Star Ambulatory Assessment, which is a common outcome measure that's being done in these boys, especially in the ambulatory boys. Then there are other timed function tests that can be used as well. What are the different ways to measure the dystrophin protein expression? So one way would be actually to look inside the muscle cells. Is the transgene even present? They can look at the vector genome copy numbers per nucleus. And then is the desired protein made? That can be looked at by Western blot. Then we can also do immunofluorescence to actually look at the dystrophin staining of the muscle fibers. Let's talk a little bit about this North Star ambulatory assessment. And this is being commonly used in the clinics for these boys, and it's typically done by our physical therapist. And it assesses 17 items of motor function that are listed below and score from 0 to 2. And the maximum score is 34. The higher the score, the better the function. This graph, you could see the natural history of the North Star ambulatory assessment score in these boys. And as you could see, these patients have peak score of 26 around 6 years of age. So starting at 4, the score tend to increase and they reach the peak around 6, and then it starts to decline. It is important to keep this in mind, as most of these clinical trials use this as an outcome measure. Some of the other timed function tests that's being used in these studies include what's called time to raise. That's just you tell these boys to lay down and then stand up as fast as you can. You can also measure what's called 4-stair climb, how much time they take to climb 4 stairs. There are other tests such as 10-meter walk, 100-meter walk, 6-minute walk test. These are some of the functional outcomes that's been looked at. In addition to these functional outcomes, some trials are also looking at the pulmonary function test as well as the cardiac outcomes. So now we'll talk about the different clinical trial programs that have dosed patients with microdystrophin or minidystrophin for Duchenne muscular dystrophy. The first one is the Sarepta program. They call SRP 9001. They have phase 1, 2, and phase 3, which just began enrollment in October 2021. So we will talk about their phase 1 and phase 2 results. This is the SRP 9001. Again, this is their construct, and they use vector AAV RH74. And this is how they call the product, delandestrogen moxaparvovec. It's 101, 102, and Endeavor. So 101 and Endeavor are the phase 1 studies. So let's touch base on trial 101, which is a phase 1/2A open label study that included 4 subjects. You can see the inclusion-exclusion criteria. And of course, one of the key things that we want to make sure is these, any of these trials, we want to make sure, since we are using this vector, these kids were not exposed to these vectors before. So they usually check the antibodies for the corresponding vector, and that has to be low. Otherwise, these therapies may not be effective. So they have to have low titer of AAV-RH74 antibodies for this trial. And of course, at 12 weeks, they do a muscle biopsy, and then they will be followed up for 5 years to look at these other outcomes. So this study has not seen any serious adverse events. There were some treatment-related adverse events noted, and most common was vomiting. And all of these adverse effects mostly occurred within the first 90 days. And there were no adverse events noted in years 2 to 4. And all of these adverse events were resolved. Then what about the protein expression? So they had looked at the immunofluorescence, which had showed about 80% of muscle fibers were positive for microdystrophin. If you look at this picture, as an example, in patient 4, look at the pre-treatment and post-treatment, and this red lining of the muscle fibers, so it's the microdystrophin expression after the infusion. And they also found dystrophin expression using Western blot with the mean expression of dystrophin 74.3% of normal. Here you could see the microdystrophin that is highlighted on patient 4, pre and post. You could see pre, there was no expression, and post dosing, you see the expression of the microdystrophin. So this slide shows the functional outcome after 4-year follow-up. Of course, this is the North Star ambulatory score over 4 years. The blue line indicates the subjects treated with gene therapy, and then the purple line indicate the external controls. As you could see, the scores, there's improvement in the North Star ambulatory score from baseline to the year 4 follow-up. And you can clearly see the difference between the controls and the treated subjects. So there is improvement in the functional outcome, which is a short-term improvement to year 4. And similarly, the improvements were also noted in other timed function tests, including your time to raise, four-stair climb. So moving on to clinical trial 102, which is the phase 2 trial, and it included boys 4 to 7-year-olds that are ambulatory. There's part 1, which is a randomized double-blinded part. And then part 2, whoever were getting placebo in part 1 would be moved to the treatment arm in part 2. And then part 3 is the open label follow-up for 4 years. So as far as safety, it's similar to 101, nausea and vomiting being the most common. There were some instances of rhabdomyolysis and increase in the liver enzymes as well. Then protein expression. There's robust dystrophin expression that was noted by immunofluorescence as well as with the Western blot at week 12. This is the functional data of part 1, which is the placebo-controlled part at 48 weeks. The kids were stratified based on the age, 4 to 5 and then 6 to 7. Here you could see the North Star ambulatory scores at baseline compared to 48 weeks. The purple line indicates the kids that received the actual gene therapy product, and then the yellow indicates placebo. As you could see, there is statistically significant difference in the North Star ambulatory scores. And their North Star score at baseline is pretty comparable in this 4 to 5-year-old group. And again, this says that gene therapy actually improved short-term functional outcome. On the other hand, in the 6 to 7-year-old group, they hadn't seen a difference. In fact, the kids who received gene therapy product had lower North Star ambulatory score. However, the reason that's thought was at baseline, their NSAA scores did not match well. All right, this is also the functional data of the same 102 study in part 2. So this is where the kids that received placebo at part 1, they were moved on to get the actual gene therapy. So the purple line indicate those placebo crossover patients. And then the yellow line indicates the external controls. As you could see, there's difference in the North Star ambulatory scores between those two groups. And also there's improvement in the North Star ambulatory score from baseline towards the last 48-week period in the kids that were treated with gene therapy product. Again, confirming that this gene therapy does improve the short-term functional outcome. We're going to move on to the next clinical trial from Sarepta, which is also a phase 1. They call it Endeavor. What is the difference between these two? Is in this, between the two phase 1 trials, as in Endeavor, they actually use the commercially processed material as their investigational product. So meaning that this would be the product that will be used once the product gets approved by the FDA. So here you see the key inclusion criteria. Then they've actually excluded patients with certain mutations because it is thought to be that patients having mutations within that region are at risk for having more immune-related side effects. We'll talk about that in a minute. Then, of course, they'll get dosing. It is open label. Then will be followed up for 12 weeks. They'll get a muscle biopsy, and then at 1 year, they'll get the functional measures, which is your NSAA and other functional outcomes, as well as safety and protein expression. As far as safety, again, consistently, the most common side effect was vomiting. And actually, one patient had increased liver enzymes that was treated with IV steroids. And there was no clinically relevant complement activation was noted. And this is this serious adverse event was one that I was referring to before that actually led to amendment of the protocol to exclude kids with mutations between 1 to 17 exons. One patient had immune-mediated myositis, and one patient had myocarditis. This is protein expression in cohort 1. So as you could see, there's robust dystrophin expression. And here you have the 12 weeks post-infusion muscle biopsy pictures. And if you look at the middle column, you could see the dystrophin expression, the red lining of the muscle fibers. And then the functional outcome, again, North Star Ambulatory Score, 1 year post-infusion. As you could see here in this graph, from baseline to week 22, there is improvement in the North Star Ambulatory Score. And you could also see improvements in the other timed function test. And all of these point towards improvement in the functional outcomes in the short term. It is too soon to comment on the long-term benefit. However, based on what we know, there is improvement in the functional outcomes with the data that we have so far. So now we're going to move on to the next program, which is from the Solid Biosciences. And this is a phase 1 trial, and they call it Ignite DMD. So this is their gene therapy construct. It is a phase 1/2 trial, and they use AAV9 vector. So this is their key inclusion-exclusion criteria. They included 4 to 17-year-old ambulatory kids. There was no any exclusion based on their mutations. And they used 3 patients with low dose, 6 patients with high dose, and then 3 patients with controls. And they would have muscle biopsy at 90 days. And then these are the primary and the other outcome measures that they looked at. The safety results from this study, there were 5 serious adverse events noted. 3 of them were due to the complement activation that actually caused what we call atypical hemolytic uremic syndrome. And 2 patients actually had immune hepatitis, and all of these were resolved. And there was no adverse events noted after 90 days post-infusion. So this about the protein expression in this study. As you could look at 3 months, and also at the last time point, there's robust expression of the dystrophin protein as noted by the Western blot, as well as by the number of percentage of positive dystrophin fibers, as you could see here, ranging from 10 to 70%. These are all data from the high dose cohort. And here you have the picture of the muscle biopsy that shows the microdystrophin expression at 18 months from 1 patient. So this is the functional data at 2 years, and this is from patients 4 to 6, also the high dose patients. If you look at the North Star ambulatory graph here, the blue line is the ones that received the gene therapy product. The dotted gray lines is the natural history data, and then the black line is their age-matched controls that they used. As you could see here at the 2-year mark, there is 4.3 points increase in the North Star ambulatory compared to the natural history. In this 2-year data showing some improvement in the North Star ambulatory assessment. And if you looked at the other outcome measures that they used, also showing some improvement compared to the natural history data. So now we'll talk about the Pfizer study. Of course, the FDA had placed a hold for the study in December 2021, but the hold was lifted in April 2022. We'll talk about that in a minute. This is the Pfizer gene therapy construct, and they've used AAV9 vector. Their product is called Forwardedstrogene movaparvovec. Their phase 1b trial is open label, and their phase 3 trial is called CIFRIO, which is actually ongoing right now. So this is the key inclusion criteria for the Pfizer phase 1b trial. They included both ambulatory and non-ambulatory boys with Duchenne, and there's high dose and low dose. 2 months after infusion, they'll get a muscle biopsy, and then these are their primary and other outcome measures that they looked at. The hold was due to a death that happened in the non-ambulatory cohort. That was in December 2021. After careful review of the documentation and the adverse effects, FDA actually lifted the hold in April 2022, and they were allowed to move forward with their phase 3 trial, which is now ongoing. This is the protein expression from their ambulatory cohort from phase 1b. As you could see, there is robust expression of dystrophin at 2 months as well as at 12 months, as measured by the dystrophin levels, also by the immunofluorescence. This is the functional data of their ambulatory cohort at 1 year. The natural history curve of North Star ambulatory assessment. The blue arrows indicate the low-dose subjects and the red arrows indicate the high-dose subjects. As you could see, the North Star ambulatory scores actually deviate from the natural history curve, which again shows that there is short-term improvement in the functional outcomes after the gene therapy. So now that we have covered the data, all the ongoing clinical trials, I want to just talk about the goals of treatment that can be applicable to these boys. I think it is important to set expectations when we talk about this gene therapy in the clinical trials or even treatment with the families. So we're going to encounter the boys with Duchenne muscular dystrophy in different stages of disease and with different functional levels. So the goals for therapy actually vary based on what level of functioning and what level of disease they are at. For example, for a kid who's in ambulatory phase, it would be important to prevent the loss of ambulation or even delay the loss of ambulation. Whereas someone who is non-ambulatory, it would be more of preserving their hand function or upper arm function, preserving their respiratory and cardiac function, maybe preventing the onset of cardiomyopathy or delaying the onset of cardiomyopathy. So it is important to set that expectations and goals. So in summary, we went through the different clinical trial programs, and as we could see, there is a unique combination of the vector, the promoter, and the transgene has been used by different programs, and these should be carefully evaluated for future use in our patients. There are 3 to 4 clinical trial programs that are using systemically administered AAV-mediated micro or mini dystrophin gene transfers, and some of these trials are actively recruiting for patients. And data from the muscle biopsies from these studies do show robust expression of microdystrophin or mini dystrophin in the muscle. And the preliminary clinical data, the functional outcome data that we have so far also indicates some improvement in the short-term functional outcomes, deviation from the natural history, which is also reassuring. However, it is too soon to comment on long-term functional benefit from these therapies.